just looking at that Melbourne Room Auditorium and I'm just filled with these memories, these horrific memories of having to study for this exam. So yeah, welcome to my part 1 exam drills. I've got a whole primary exam playlist if you're ever interested. So you can scan that QR code and I'll take you to my YouTube channel with a whole playlist of part 1 stuff, which I'll keep adding to as I create more lectures about this kind of stuff. I mean, the first thing, I realize that this is the very last day, and I'm going to try and keep you guys engaged with lots of exercises because pretty much my style of teaching is give you lots and lots of exercises to try and practice points and practice principles. So let's do that. Yeah, so the objectives essentially useful drills for maximum impact, structures for answering questions, categorization, and learning tables of data. And we'll go through all of that in this time. Okay, so the rules are, hey, so essentially the way I'm going to do it, I'm just going to ask lots of questions. Everyone's going to have a go writing down stuff. So have a pen and paper ready. You know, get it wrong, get it right. I don't care. No one cares. You know, we really just want you to get through this exam. It is an absolute, you know, horrific amount of knowledge to try and learn, and it just keeps getting more. And I just really want you to get through it because I really think that your place as an anesthetic registrar is for when you're beyond this exam and then you start actually getting into clinical work. So get past this and start becoming an anaesthetist. So yeah, this hopefully is like high intensity intervals at the gym. So just doing multiple reps of this to get you to peak exam fitness. So obviously there's people at different levels of study. Some of this might be new and some of this might be old. If not, just take it as good repetition and practice. And that should be, you know, hopefully just get the most out of it. You know, it's one of those things when especially when you're vived, sometimes you get a vive you've already heard and you feel like you're cheating a bit because someone's already asked you that question. No, don't feel that way. That's exactly how it should feel when you get into the exam. Hopefully every question will be old news and you'll be like, yeah, I've heard this before. You want it to be so boring that it's like a walk in the park. Now, a few things that are probably common knowledge. So, you know, for every physiology question, you know, maybe not every, but almost all the physiology questions, I had a structure where essentially I put down a definition, I put down some normal values if that's relevant, definitely chuck in a graph. The whole picture tells 1,000 words. So put a graph in if possible, and then categorize the answer for causes or types of or factors of whatever it is. And that just allows me to get all the, you know, critical points and framework down for my answer and then crack on. And, you know, if you want to know how I like literally, you know, you've got your paper, your short answer question paper, you know, my different causes of or factors of is almost like one heading for half to one page. And I'll just put those down as the full structure. So then I'll just fill it out. And that way I'd make maximum use of my minutes without spending too much time on one section. I never want to go over that 10 minutes. Pharm structure, similar stuff, intro, dose, pharmaceuticals, kinetics, and dynamics. I'm sure you've all heard of this. And then the extra thing that I only added later into my practice was drug factors and patient factors. So if you think about it, you know, if someone asks you the respiratory effects of opioids, you could get your normal stuff down about the respiratory effects, which is a pharmacodynamics question, but that's only part of the answer because you can always volunteer more information like patient factors. Or, you know, this patient had COPD or had other you know, sedative or respiratory depressant drugs on board, the effects would be summative or something like that. And that way you can just create marks and create marks by creating instances that are relevant to the question. So that was my whole framework for pharm structure. Now take that with a grain of salt because obviously the question may be very different overall and might have some more clinical applied anesthetic stuff in there, but this was the basics that I wanted for every question. So the next thing is I think broadly there's 2 types of questions, and you'll definitely see this in the final exam, but it starts off in your primary exam. So there's 2 types of questions: are specific questions and broad questions. Now, your specific questions are quite obvious, right? You know, you either know it or you don't know the answer. For example, what is the pKa of alfentanil? And so you hopefully know the answer, you give the answer, it's fine, and you move on to the next question. Now, broad questions are a lot of what, you know, this exam is a combination of both really. So broad questions are more like, you know, it's a broad question. You have lots of potential answers. And I think the best way to show the vast scope of answers rapidly is with a good structure to categorize these things. And this is something that was very new to me, but it was something that, you know, pretty much the first part exam started this off for me in the way of answering questions. So if there's anything that the first part exam or the primary exam gave to me, was this just absolutely, the diligence of structuring everything I know, because without that structure, broad questions have just too many answers that is just nebulous. It's just so hard to get to the answer that's required without a structure. So, for example, what are the factors that affect speed of onset of an IV opioid? You might say these can be related to fixed law of diffusion, that is concentration gradient, molecular weight, solubility, area, and thickness. Now, I think the combined approach, definitely something in the final exam that's super relevant, but also in the primary exam. You want to try and give the examiners the specific thing that's the most relevant answer or point of difference for that drug or for that situation. Because that way, you don't necessarily go into too many things that are kind of not what the examiner is potentially asking for. So what factors affect the speed of onset of an IV opioid? I think most theories say that so you might start off, this could be explained by fixed law of diffusion, but a low pKa is the most significant factor. Other factors being this. So let's say you're in the exam and you get asked that question. You've shown that you have a broad perspective of the answer, but then you've also gone in with what's most likely the answer they want to hear, which is the low pKa situation. And then you quickly follow it up with other factors. So, in that situation, imagine you just started talking about, well, the onset can be due to thickness. Maybe, the patient's got some kind of thick membrane, and you start going into the thickness thing. First of all, you're not probably telling the most relevant thing to the situation, but also you haven't shown the whole scope of that the answer. And again, this is probably more of a time wasting thing than an actual problem with your answer. You don't have enough time in the exam, and the exam is a game, and you need to move quickly through it and allow the examiners to give you marks. So my opinion is that the combined approach gives you the answer they want and shows a solid structure to cover all potential answers rapidly. So let's get started with this. For respiratory, so I've just broken this up into respiratory, cardiac, and I think I've got renal and neuro as well, but any topic can have this kind of format of categorization for your answers. So why don't we just go through some of this? So unfortunately, I don't have names in the Melbourne auditorium, so I'm just gonna, I guess, ask people in the who are in Zoom world, and let's just see who I've got. So hey, so now what are the factors affecting controlled respiratory? I want you to take a minute, and I want everyone to write down just the categories. How could you categorize this to make it organized and structured?
I guess the broad categories that I'd sort of split it into are sort of chemical factors maybe, and then thinking about neural factors, hormonal factors, and then sort of other factors which would give me a broad category to frame the answer.
I love that you said that, because you pretty much got the ones I did. So for example, the blood stuff, or blood factors, CO2, O2, pH, this is the most important, so I've chucked it there. I've just put in, I've also got hormonal factors and other stuff. And when I think about it, I love the fact that you put other, because that also just allows you not to have to think too hard. Imagine you're in the Viva, you're trying to get something out quickly. How do you categorize the IV induction agents? Barbiturates and other, or muscle relaxants. Oh, I forgot what they are. Depolarizing and other, or non-depolarizing and other. Bad example. But you can think of a situation where you just want to get some answers down. And so I like your structure and the fact that this is a topic where most of the other non-blood factors are, a bit random. Everything from lung receptors to exercise to just cortical stuff as well, and voluntary stuff. So that's exactly what we're doing, Adam. Just broad stuff, getting it out quickly, because that's how you get the marks quickly and move on in the exam, whether it's the Viva or the short answer question. I've also got here drug factors as well. Now, if anyone has any questions or has something that they want to ask about in each of these things, or just clarify, absolutely. I'm definitely not presenting the gold standard of things. This is just the way I did it for my exam. So let's go with causes of hypoxemia or low PaO2. Take a minute. What do you reckon?
Hey there, here. I have hypoventilation, so decrease in tidal volume, decrease in respiratory rate, decrease in minute ventilation, as well as alveolar ventilation. I have decrease inspired oxygen, FiO2, and so perhaps in altitude, for example. VQ mismatch, shunt, and diffusion impairment. That's what I have for it's sort of like a specific categorization for this question.
Yeah, that's perfect. And you mentioned low FiO2, but you correctly said, funnily enough, it isn't actually low FiO2 because at high altitude, the FiO2 is the same.
It's the same, correct. It's the atmospheric pressure that's decreased.
Yeah, exactly. Yeah. So yeah, your answer, I always say low FiO2 as well because I'm at altitude, I'm at normal sea level roughly when I'm ever diagnosing these problems, but really it's the barometric pressure at the alveoli.
Correct.
So perfect. That's great.
Yeah, sorry. Yeah.
No, you were correct. I like that you raised that, because that's completely correct. Now the interesting thing with this, just again as a side note, as I'm doing this, like there's so much content in this exam. I remember thinking, I just can't go through enough stuff recently if I do it in a full way. So this is by no means saying not learn the detail, but I found that if I just drilled these categories before the exam, like in the weeks before the exam or the Viva or whatever it was, I was able to cover a lot more ground. It also helped me to, just get the confidence that, yeah, it's at the tip of my mind. I know the categories, therefore I feel safe in this exam. Likewise, if I was just, going for a coffee with a friend as a study break, I would just ask these questions. So it'd be a bit more interesting than writing a whole 10-minute question. You could just have a chat about these things to get quick answers on the board. Okay, causes of hypoxia. I'm just going to take 30 seconds.
Right, I started with the definition.
Yeah, go for it.
Saying hypoxia is reduced O2 delivery and to the tissues.
Yeah, go for it.
And the main causes are started with hypoxemic hypoxia, and with definitions PaO2 less.
Again, sorry, and one of these strategies is going, don't give me the definition, just give me the list, and then if I want the detail, I'll ask you for it. So keep going. Yep,
hypoxemic, anemic, stagnant, and I missed the fourth one. I forgot it.
Actually, I reckon you can get it. Have you heard of is it one of our lecturers? I don't know if he still does this. Abe Imranica. He talked about the train carriage analogy. So you've got your carriages, which is HB. You've got the people in it, which is oxygen binding to HB. You've got the train moving with the engine. That's the pump. But once it gets there, it's a little bit glitchy, is it? I'm going to pause for a second and tell me if it's still a problem. Okay, cool. Thanks, guys. I'm so sorry. I've got just variable reception here, but if it keeps getting glitchy just constantly, I'm just going to move to another area. What do you reckon? When the train gets to the tissues, what could be a problem there, or the station? What could be a problem there?
Like the tissue can't utilize the oxygen.
Yeah, what's that called? And what could be a cause of that?
Shock, isn't it? Or
yeah,
stagnant?
Yeah, no, that'll be the cardiac problem, the stagnant thing. What happens if you have too much carbon monoxide? Or better yet, carbon monoxide has multiple effects on the cyanide toxicity. It affects that electron transport chain and just stops you utilizing the oxygen at the tissue site. So anyway, that's beside the point. Your categorization.
So it's on the tip of my tongue, but
yeah, no, you're
cytotoxic. Yep.
Go on. And again, the important thing, does it really matter if you just don't get that one in one moment? It doesn't matter at all. You're really good in getting those main points there, as well as the definition. Okay, next one, causes of an increased AA gradient. Take 30 seconds.
I would have just said diffusion, VQ mismatch, and shunt.
Perfect. Diffusion, VQ mismatch, and shunt. Oh, the one extra thing I've added there is the transit time. When you have diffusion abnormality versus perfusion abnormality, and then that transit time increase. The fact that something can turn from a perfusion limit to a diffusion limit of gas can make a problem there. So that's the other thing, but I totally agree with you. Okay, next one, causes of hypercapnia. So take 30 seconds.
All right, so I had hypoventilation, so iatrogenic, so we've done something to them, or metabolic.
Say it again. So either it's going to be hypoventilation, and was the next category metabolic?
So iatrogenic, so we've given them a pneumoperitoneum with carbon dioxide. Or then metabolic, so they've got malignant hypothermia, or they're septic and they're just chewing through and making more carbon dioxide.
Yeah, good. Yeah, very good. So,
and I suppose a whole bunch of central things also causing decrease of hyperventilation.
Yeah, that's right. So once I've got, and you'll find that the way you'll do this is that you'll have categories for each of these individual things, and then that category is something you can then mix and match with another section. It just feels like having to learn less knowledge in the end of it. Yeah, so decreased alveolar ventilation, the /CO2 elimination. I've just chucked in CO2 elimination. Hey, you might not know this. Have you ever used Ali Mapleson circuit?
I haven't.
Oh, all good. Has anyone used a Mapleson circuit? And do you know what happens if you decrease your gas flows? For example, in a normal closed circuit, you might run 1 to 2 liters per minute. But if you run that in a Mapleson circuit in a child, do you know what happens with CO2?
So they would rebreathe their CO2 if the fresh gas flow is not 2 or 3 times. Well, it depends on the type of the Mapleson circuit, but if it's not 2 or 3 times their minute ventilation, they would rebreathe CO2.
Perfect. And the next question you might get asked in the exam, as a more applied, you're getting to a good side of things. What does the end-tidal CO2 trace look like in that situation?
You would have a high inspiratory CO2, so it's not from 0.
Okay. Perfect. Yeah, and that's great. So when I first started kind of making these tables, PaCO2 is proportional to production and inversely proportional to alveolar ventilation. But then I realized that that's actually not true in the anesthetic context if they've got a Mapleson circuit. So then I modify that to alveolar ventilation or CO2 elimination, because if I don't have high enough gas flows in a Mapleson circuit, that doesn't hold true. So yeah, otherwise decreased minute ventilation, gas flows, even soda lime issues, so that you're rebreathing stuff. Let's keep going. So then this comes to what are the causes? All those causes of decreased minute ventilation. That was one part of the previous one. I might ask, maybe take 30 seconds.
This might be a little bit cheating, but in terms of minute ventilation, I would just say anything that decreases tidal volume or anything that decreases respiratory rate.
Not cheating at all.
You could classify those further, but yeah, just those 2 factors mainly.
And that's fair that you did it. My classification is very different. But it doesn't matter, because as long as you're putting an answer on the ground that you can quickly put out to show a framework, you get to the answer hopefully quickly. I've got here upper motor neuron, lower motor neuron, neuromuscular junction problems, chest wall, VQ diffusion, and shunt. And these it just helped me to identify all the different causes at each level that causes ventilation. But you're completely right to say things might affect minute ventilation or rest rate. Or alveolar ventilation as well. How about this one? The causes of venous admixture.
I think I'd say I'd split it up into things that decrease alveolar ventilation or things that will increase perfusion. And then just add things to both those categories.
So what's another way of saying decreasing alveolar ventilation to the perfusion?
So that would be things that cause a low VQ ratio.
Perfect. Yeah, VQ mismatch. Absolutely. Keep going. What was the other category?
And then I guess that was related to that. It was increased perfusion. And then there's the other physiological things like the Thebesian veins and the bronchial circulation.
Yeah, good. So what are those examples of?
Examples of shunt.
Exactly. Beautiful. What kind of shunt are there? Like, how would you describe the different kinds of shunt? Because Thebesian and bronchial are a very specific kind of shunt.
I'm not sure.
No, that's all good. What is pneumonia, or what is Eisenmenger's?
Oh, so left to right and right to left shunts.
Yeah, right to left shunt. So which are essentially just pathological shunt. Again, you can categorize this whichever way you want to be able to get the answers right. In my notes, this is just how I had it. Physiological is the bronchial veins and Thebesian veins. And then pathological is just all the causes of wherever you might have right-sided blood bypassing oxygenation in the lungs, whether there's lung issues or it's intracardiac pathology and communications like right to left shunts and malignancies and Eisenmenger's and AV malformations. VQ mismatch is the interesting one for me. Like, do you have a definition of venous admixture?
So it's basically it's all the things that cause a VQ ratio less than 1. So it includes shunt, but then also all the low VQ lung units.
Yeah, like it's this. I also find it interesting because it's like this theoretical value, which is exactly what you're saying. It's a theoretical amount of blood that must be added to mixed venous blood to account for the to pulmonary capillary, but to account for the difference between your end capillary and your arterial PaO2. So, that's just this very specific definition about what it is. And VQ mismatch seemed to be like this really odd thing where, you just have these imperfect lung units that aren't oxygenating as best as they possibly could. And that accounts for these little bits of theoretical shunt blood, which you add in to the pulmonary capillary. So I thought that was just a really interesting concept for VQ mismatch. Let's keep going. Causes of airways resistance. So take a minute. There's probably so many different ways of organizing this. It'd be interesting to get your thoughts on this. So
I think my immediate thought was to do it anatomically. So in terms of like upper airway resistance and lower airway resistance, and then take it from there.
Okay. And how would you keep classifying those if you were to branch out?
I'm not sure exactly. I mean, you could do it like upper airways. So you could do like nasopharyngeal, nasal, pharyngeal, laryngeal. And then
I do like the idea of anatomical, and to me that feels like it's one whole category.
Yeah.
And if you were to then think of a couple of another category, what could you come up with?
So you could have like pathological and drugs.
Yeah, absolutely.
Hey, I sort of went with fixed equation, just using that as a sort of way to sort of delineate the resistance and just the length, viscosity, and then obviously radius having the most significant effect because length and viscosity tends to be maintained. And then I talked about...
Is that fixed law?
Sorry, no, it's Pascal's law. I apologize.
No.
Sorry, it's Hagen Pascal's law. Sorry, I've got that mixed up. It's been a long week.
There's only 2 laws, right? Fixed and Pascal's. That's
yeah, and I managed to get that wrong. So I've got it written down on the paper. It's just been a very long week. But and so I sort of went with that, and then with sort of muscular wall sort of problems, and then I went with airway in terms of radius, and then pathological versus physiological. So physiological, you could go into conditions where you get that myogenic response, hypoxic pulmonary vasoconstriction, and how that would relate to narrowing of airways, and then pathological processes whereby, for example, asthma, you get edema and increased swelling of the airway, which narrows it, and you could discuss those things.
Yeah, good. So I really like the fact that you did mention the Hagen-Purcell equation, because I found that very easily reflects how I can just capture a lot of things. And just like with like with my whole broad system or combined approach, you might say Hagen-Purcell equation, and then make sure you mention that radius is probably the most important, and that way you can go straight into the money differentials. But then, I mean, as I kept doing these classifications, and you're really correct in saying that you might have to keep adding on things. For example, the first time I did this, I didn't think of lung volume, and then in the anesthetic context, I didn't think of the end tidal, so the ETT, as causing a decrease in your radius. Therefore, it's going to contribute to airways resistance. So it just kept on evolving as I did this. And then finally, I went to, but turbulent flow has different rules to laminar flow. So at that point, this is what I ended up with: laminar and turbulent, where laminar I talk about Hagen Purcell, and then I've got other factors like lung volume and the ETT as well. Again, I'm definitely not saying that this is the way you should do it. The whole concept of this is to get your answer out quickly, to be able to communicate effectively that you have a structure, to move to what the examiners want you to say as effectively as you can. And on the extra points for being able to go through more and more topics quickly, and having this, this snapshot summary of a whole short answer question or a whole Viva topic, I found really useful.
Would you include the lung volume sort of with regards to radius and the sort of radial traction and that, or you do it as a separate way of, and talk as a separate topic?
I literally, as I was watching this, I was like, yeah, actually, that's very much a radius thing, isn't it? So I don't think it matters too much, but chuck it into radius. That makes a lot of sense.
Cheers.
Factors that affect lung compliance. So yeah, take 30 seconds.
So I divided it up into static and dynamic. So for static, I said elastic factors, surface tension, and lung volume factors. And then for dynamic, I said time-dependent behaviors of the lung, as well as all the static factors.
Yeah, fantastic. I did something pretty similar. So I had lung factors and chest wall factors. And then I kind of added the dynamics compliance. It just made sense to me to add it as a separate thing. But yeah, and then within lung, I've got my volume stuff and my elastic stuff and my surfactant as an extra point, and then chest wall things, only because compliance. Why? The reason I've done it there is because I've got these two very obvious physical parameters that I can categorize things in. Yep, and then dynamic compliance, increased airways resistance, bronchoconstriction affects that, and the time constants or the time-dependent nature of each of the lung units, which you mentioned. Absolutely. Cool. Factors that affect FRC. So again, take 30 seconds and I might ask. Yeah.
I couldn't think of one to pick. There was just like a lot of different things in a list. So I started thinking of the things that affect it and the definition, but I couldn't pick one that I liked. Like I was thinking things that affect the lung, things that affect the chest, then like pharmacological factors, physiological things. So I didn't really come up with one that I liked. Sorry.
I think what you've said is actually pretty good. So I think, just to reiterate, you've said, I mean, you've probably thought about the definition, and it's the balance point between the lung recoil in and the chest wall recoil out. So you've said lung factors and chest wall factors, and then mentioning drugs and anesthesia. That seems reasonable. I mean, I think you've just come up with a pretty decent category there.
Cheers.
So this is what I've got: chest wall, lung, airways resistance, because that causes dynamic hyperinflation, and then PEEP, because that's something we apply. So again, I started out with chest wall and lung because it made sense for the definition. And then I have to add these other things as I hear about them. Okay, factors that affect dead space. Yeah, so take 30 seconds.
So you could split it into like your anatomical dead space, physiological dead space, and then have factors that affect both of those. So you could think about like the circuit being like that would increase your anatomical, well, that would increase your anatomical dead space.
Actually, just as a
or
point,
that would, yeah.
What is the anesthetic circuit called technically? As in, it's not part of the innate anatomy of the.
No.
Yeah, it's got
like apparatus.
Yeah,
dead
perfect.
space.
Apparatus dead space. Yeah, good. So then going to anatomical and physiological.
Yeah, and then I would just expand on those.
Yeah, beautiful. So I've got here anatomic. I didn't have anatomic and physiological apparatus, but I actually really like that categorization. I almost wish that I did that, because then I could just chuck in drugs into the physiological factors. Positional could be part of anatomic, but it also affects ETT and attachment, which is apparatus. And then alveolar, that would be physiological as well. So you know what? I think I do prefer your definition. It's been a while since I've ever done this kind of categorization, but yeah, I think that's a really good way to go. Okay, factors that affect worker breathing. And you'll notice that this might be a combination of the stuff that you've already told me for previous categories. So take 30 seconds.
I actually didn't have a good way to put this until Stan actually did his session earlier in the week. But I really liked his splitting it into surface
you don't have to
tension.
credit. You don't have to credit Stan. This is it's fine. No one has to know.
The surface tension, elastic recoil, airways resistance, and then tissue resistance, sort of subheadings.
Yeah, good. And just tell me the first one again. Surface tension, was it?
Yeah.
Yeah, good. I've added that into my elastic factors, but again, who cares? You're putting it out there because you've said in your assessment that that's a really important thing that's worthwhile putting as its own category. Completely fine. I think it's part of elastic factors, and you could, if you did it another way, you could point that out that is the most important of those factors. And as you can see from what I've done here, elastic then becomes lung and chest wall stuff, and then your non-elastic, which is your airways resistance, is your laminar turbulent lung volume ETT or Hug and Purcell stuff. And then tissue resistance is the extra thing there. See, what I like about this is as long as you've got those categories, you only have to really learn one extra piece of information for this if you keep everything else constant. Factors that affect pulmonary vascular resistance.
I don't have a good categorization, I think, but I said lung volumes, blood volume, and metabolic factors.
Yeah, nice one. The lung volume, because that's obviously at the and what lung volume is pulmonary vascular resistance the least at?
FRC.
Yeah, FRC. Nice one. And what did you mean by blood volume? You're absolutely right. There's something. What is specifically about that?
You get recruitment and distension with increasing blood volume.
Perfect. What was the other factor?
Metabolic factors.
Yeah, tell me about that. How do you?
Like with hypoxia, pulmonary vasoconstriction, and the factors that play into that.
Beautiful. Any other factors that affect the that are in that realm?
Yes.
Yeah, no, that's good. So when I think of I think of like the drugs as well, because obviously they're these molecules that affect the smooth muscle, so it makes sense that I can include those. But yeah, pulmonary artery pressure, which is cardiac output, gravity, West zones, that all comes under those blood factors that you mentioned. Lung volume and FRC, it's least. Hypoxic pulmonary vasoconstriction, I mentioned it on its own because it feels like a special kind of thing. And then all the other factors that essentially affect your flow, your radius actually. So drugs, disease states, neural, hormonal, they're all just in one sentence really. They all affect the radius. And I've chucked in here viscosity as well. I just like how the patterns just keep coming up. Like after the very specific patterns of pulmonary artery pressure and lung volume and hypoxic pulmonary vasoconstriction, the other stuff is really just radius stuff. Hey, so that's pretty much the summary. Like I hope people appreciate that, doing it this way, you get lots of marks straight out. We've gone through pretty much a lot of respiratory physiology in, I don't know how long it's been, like say 40 minutes or so. So yeah, we went through respiratory factors affecting it, low PaO2 or hypoxemia. Hypoxia we went through as well, AA gradient, hypercapnia, decreased minute ventilation, venous admixture, airways resistance, compliance, FRC, dead space work of breathing, and pulmonary vascular resistance. And that's a long way towards most of your respiratory topics. Any questions about that before we move on to some cardiovascular drills? Cause of hypertension. I might just ask someone on the spot here.
So I'd approach it from a shock point of view. So cardiogenic, neurogenic, low volume, obstructive, and distributive. Perfect.
I do preload, rate rhythm, contracting, afterload, but I do absolutely appreciate that the shock classification is really, really useful as well. Good. Determinants of coronary blood flow. Take 30 seconds, and what are the determinants, do you reckon, of coronary blood flow?
So I guess you can look at blood flow, coronary blood flow, as blood pressure affecting it. So the time of diastole would be a good one. The other things you can talk about coronary blood flow, you can use what's that thing called Hagen-Purcell's equation as well to look at the rate of flow.
Mm-hmm. Yeah, good. And is the stuff like that's very specific to the heart that, like, I totally agree that you want to invoke some kind of Ohm's law type situation or Hagen-Purcell flow situation, but then the heart is very specific because it's got, you know, cycles in it. Is there anything else you could add to it? It just drops in and out when it feels like it. Yes, I completely agree. Coronary blood flow, you want to chuck in some kind of Ohm's law type thing or Hagen-Purcell type thing, but because it's a cardiac cycle, it's got some other specific things that occur. What else could you add to this?
I guess you can talk about like systole and diastole. So perfusion during those times. Sometimes you can also talk about the Starling's resistor affecting coronary blood flow as well.
Beautiful. Tell me, what's a Starling's resistor?
So that's when you have Starling's resistor describes flow irrelevant to pressure, and that's due to extrinsic forces applying external to the flow of the flow through a vessel.
Okay, give me examples of where Starling resistor has an impact on an organ.
So maintaining with the topic at hand, the heart's a really good one. So a key effect in systole on the left side of the heart is that coronary blood flow only occurs in diastole. And the reason behind that is the myocardium surrounding the coronary vessels act as a Starling's resistor.
That's good. Now, in that question, I'm going to say,
compressing upon
what are
the vessel itself.
What are the other organs that it affects? I want you to give me the list before the detail. What are the other organs that act like a Starling resistor? Yeah, I mean, West zones, if it's West zone 4, actually the lungs itself can act when the interstitium puts pressure on it. But you'll find that any single organ bed acts as a Starling resistor. You know, like the cranium, that's a Starling resistor. Capillary bed's a Starling resistor. You've got your kidneys as well. Yeah, no, that's good. So coronary blood flow, CPP over C, coronary vascular resistance, and coronary perfusion pressure is coronary arterial pressure minus right atrial pressure or LV wall pressure. That's your Starling resistor problem, whereby that equation is a differential pressure or, you know, venous arterial difference only in part of the cycle when the LV wall isn't contracting, being that Starling resistor we're talking about. And so then pretty much I just have to go to the coronary vascular resistance factors, which are pretty much all of my Hagen-Purcell type equation factors: 8 viscosity length, pi r to the power 4. And like we mentioned before, like a lot of these things are so similar. There's neural factors, they're physical factors, then there's pathology and drugs. And then in your organ beds, like unlike your airways, which you've just talked about, when I'm talking about radius in non-lung structures, then I've got to talk about order regulation being myogenic and metabolic, because again, those seems to exist in all of our organ beds as well. So again, I've just transplanted the knowledge that I had about radius factors, which was often very similar things, nerves and drugs and physical stuff and compression and pathology, and then chucked on order regulation, metabolic, myogenic, because again, I don't want to waste too much of my memory in learning stuff. I just want to be able to attach previous knowledge and just add on to it. What are the factors affecting O2 supply and demand?
So here I've split it up, and of course, into supply and demand. Starting off with supply, starting off with our flux equation. So delivery of oxygen equaling to the cardiac output. So that'll be one factor. So therefore heart rate, stroke volume. And then our O2 content, which of course then relies on our hemoglobin concentration, saturations, and FiO2. And then further on down to the demands, whether there be increasing or...
Is it FiO2 or something else?
Oh, sorry, there's the PaO2 times 0.003, and then it's SaO2, sorry.
Perfect.
And then further with our demand, that'll be dependent on metabolic activity, so the metabolic rate of oxygen particularly, and then other flow requirements as well. So then we can go back down into our Hagen-Purcell equation.
Yeah, fantastic. Demand. Actually, tell me about demand again.
So my understanding that most of the demand was due to the metabolic requirements of oxygen, and therefore requiring flow to supply that demand.
And how could you then maybe divide up the demand? Like, you know, what is it that determines the metabolic rate of heart?
So the amount of so in the heart itself, so then that'll be dependent on the heart rate itself, so the amount of contraction that's happening. So therefore, our chronotropy, inotropy, the rate of lusitropy as well, I guess, and then and other factors in there.
Yeah, that's good. And then there's some kind of smaller factors as well. But yeah, so O2 supply is exactly like just the logic by which you went through that was fantastic, because you're talking about coronary blood flow, O2 content. And that's its own thing. It's got a high, I just mentioned it's got a high extraction, especially cardiac, because it's it's just one of the specific things to the heart muscle. And the DMAD, myocardial work and metabolic work. So wall tension, contractility, heart rate, the type of rhythm I've chucked in there. Yeah, again, I after I first did this, I just kept adding on things like, oh, actually, when you're in VT or VF, you're really inefficient. So boom, that's a lot of myocardial work. And then type of work is interesting. So pressure work takes more effort than volume work. So, have you LV hypertrophy, that's more work. And then metabolic work. These are small things, the wall thickness, basal rate, and electrical activation. These are tiny factors. And again, I don't know any more than that, but it's in Byrne and Levy or Papano as it is now. And so I've chucked those in. Now, there's an interesting thing. I remember there was this one aortic stenosis question, and it was just this extra bit of kind of the high-end information that if your coronary perfusion pressure, so O2 supply, is actually dependent also not just on your, I guess, your coronary perfusion pressure of your aortic root pressure, but that pressure depends on how much lateral pressure there is. So in severe aortic stenosis, you get lots of forward, but not as much lateral pressure. Again, some throwaway line out of Papano, prescribed text, which I thought was interesting, and you know what, probably not worth it remembering because you're just here for the big pointers. But if you're bored of this, you get to read up on it. Cardiovascular effects of supine to standing. Cool. So take 30 seconds and try to figure that out. Actually, I might ask two people. So I might ask, actually, I'll just ask one person. When? Take 30 seconds.
So when you go supine to standing, you get pooling of venous blood in your legs, and that causes your venous return to drop, and that decreases your preload, which in turn, by the Frank-Starling mechanism, decreases your cardiac output and your mean arterial pressure, I think. And then that, I believe, causes your baroreceptor rate to decrease in firing, and the and by efference of the vagus and glossopharyngeal nerve causes an increase in sympathetic output, a decrease in vagal tone in response to decreased mean arterial pressure, and that causes a compensatory tachycardia as a response to renormalize your cardiac output.
Yeah, nice one. And only because it's quite a big way of answering this question, I might ask that person in the auditorium who waved their hand. What's your...
Lahira, that was when.
Oh, that was when. Oh, got it. I didn't hear all that, so I'm really confused about what happened there. Anyway, here we go. So here I've got global factors and local factors. And for the global factors, I think of these, and maybe my question was a bit obtuse there, where I'm talking about this cardiovascular effects of supine to standing. So I'm talking about the compensatory things as well. But yeah, baroreceptor atrial stretch effects, venous flow, which is your ciliary pumps and your venous return, and how it gets improved after it decreases from supine to standing, and then microcirculation changes as well. And then the local stuff for each cerebral autoregulation, and actually autoregulation in a lot of your vascular beds, myogenic mechanism, metabolic mechanisms, and then increased O2 extraction by some organs as well. Okay, let's go to neurocategorization drill. So determinants of ICP, the way I've found most useful for determinants of ICP, and it just really works well from a management point of view as well, but brain, CSF, and blood. And really the blood factors are all the things that you can rapidly change. But if you go to brain factors, the surgeon can take out parts of the brain or parts of blood clot or whatever. CSF you can drain potentially, but then blood factors is where it all is really, where you can change your posture, increase venous outflow by loosening ties. But there's also other metabolic things. So you want to keep your O2 perfect, your CO2 low normal, your metabolic normal as well. And then there's nervous systems. Now, the reason blood pressure, like ICP isn't proportional to blood pressure is when you've got that autoregulatory plateau. And I won't go through it in too much detail, but the blood pressure has sometimes proportional and sometimes indirectly proportional effects on your ICP, where outside of, if everyone's very familiar with that cerebral blood flow to CPP plateau between 50 and 150, on that plateau, increasing blood pressure in a normal brain decreases ICP, whereas outside of that plateau, you do potentially get an increase in ICP if there's an increase in blood volume. Cool. And then correction of raised, I've pretty much just gone through that. So blood factors, CSF factors, and brain factors. Again, depending on how applied this first part exam gets, this is kind of going into final exam stuff, but it's all just Munro-Kelly doctrine stuff, really. Blood, CSF, brain. I haven't put interstitial stuff there, which I probably should have, but that's probably in brain, where if you, I've actually mistakenly put it in blood factors. So pharmacological, mannitol, and hypertonic saline, that's actually brain interstitial volume reduction. So I apologize for that. And then moving on to categorization drills for renal. How does the kidney establish a concentration gradient? Now, there might be a few different methods of answering this, which is completely fine. Feel free to use mine. I found reading Vander's, as bad as renal physiology was to read, I felt like Vander's helped as much as possible. And this is what I chose to do. Countercurrent multiplier establishes the gradient. Countercurrent exchanger maintains that gradient, and the role of urea just adds 50% to your maximum concentrating ability. So yeah, that's pretty much what the way I did it. And then you can chuck in ADH into that, because that's obviously a big part of the hormonal response. So maybe that could be other or hormonal as well. Cool. We don't have to go into the detail of that. There's plenty of stuff on there. How about renal handling of acid? Again, very specific stuff, but again, it just really helps to have a framework for this.
There's acid secretion / bicarb reabsorption as number one, titratable acid secretion, and ammonium synthesis and secretion.
Beautiful, love it. Reabsorption of bicarb, or acid secretion, titratable acids, organic acids, and ammonium, fantastic. And I remember getting this in my Viva and literally just saying those 3 words, and then they just moved on. It was so satisfying to have given them a category and then moved on. It was like proof of concept that this is kind of what they're looking for. This gives them confidence in you. So fantastic, Ushan, redeemed. Factors that affect GFR. And so all I've got is that when I read GFR in the prescribed textbook, it talks about these things. And a couple of easy things to talk about: filtration barriers, endothelial fenestrations, basement membrane, the foot processes, and then molecules, size and electrical charge, and then Starling forces, which is the whole topic of your coefficients and your oncotic pressures versus your pressures. That said, to have your framework for the renal blood flow, which seemed absolutely fine, all you got to do is add this kind of specific GFR topic to that. It's all about highlighting that point of difference. I briefly mentioned, when you've got lots and lots of data that you need to express, but chances are they just want one piece of data or one area of data. How can you get that quickly? And this is what it's about. I want you, in your experience of the exam, to start, especially at this point, even now, you've memorized lots of information, and start finding out in a situation what the most important critical point is. And so this is really applicable. This whole concept is very applicable to stuff we've just talked about, but also to pharmacology tables. So I thought this would be a really great exercise in trying to learn something that's just so difficult to learn because there's just so many numbers. And if you're not in a savant, I remember what I had to do was I had lots of transport jobs when I was doing ICU, and I'd literally just sit with some sick patient in MRI for ages, and I'd just write out these tables. But not everyone has that luxury to memorize these things. I do feel like I probably wasted a bit of time, so I don't really have to use that knowledge ever again. But if I had done this, which is what my study mate did more of than I did, I would have wasted a lot less time. So the pharm tables, so write down the dose, volume, distribution, clearance, half-life, protein binding, and metabolism of thiopentone, propofol, ketamine, and etomidate. I'm actually not sure that I meant for you guys to do that. Yeah, so this is your table. I want you to take, I mean, instead of trying to fill it out number by number, I just want you to give me the most qualitatively important numbers or concepts within this. What in each category, which drug stands out as most notable? And if you can remember the number, fantastic, that's great. If not, just give me a qualitative, like high or low or average or something like that. And let's see how much we can get. See, at the end of a minute, so just try to get this done. At the end of a minute, I'll just volunteer what I've got. But I really want you guys to commit answers to the page. Qualitative, what is the most important in each category? What's significant? So I'm going to just take a minute for everyone to go through that. You could try to learn this. I mean, learning a table is hard enough, but you got ranges of numbers there as well. It just gets tricky. I'd say if you wanted to learn the numbers, just pick one number rather than the range. It'll be fine if it's within that range. But when I think about this, all the doses are known to you because you've probably used them, and if you haven't used them, please use them in your practice. You can always find a reason, except for etomidate or methohexatone. You can always find a reason to use thiopentone. Next appendix or next rapid sequence induction, thiopentone is the go-to for many, many decades. So use it. Ketamine, if you've got a long case, especially in anyone that's got any sign of pain, just do a ketamine induction, get used to the doses. Volume distribution, it's always large. Clearance, low for thiopentol, high for propofol. Elimination, half-life is large for, very high for both these. There's some large ranges. And then protein bindings, high for everything except for ketamine, which is low. And then ketamine, I think my internet connection is a bit unstable, so I'll just wait for a bit. And then thiopentone and ketamine have active metabolites. And that's probably the most, important stuff there. And that was just the table there, just to remember. Okay, so try this for physicochemical properties of inhaled anesthetics. So again, take a minute or so and just use this as practice to try and get some qualitative comparative data down. Okay, so just to talk through this, I mean, again, this is a large table. There's some things that are probably worth memorizing in this table, like the blood gas partition coefficients. But yeah, this table, really big, right? Really hard to learn. But if you learn, there's a few numbers that are pretty impressive here. Like in molecular weight, I've never been asked this, but nitrous is obviously the lowest. It's just 2 nitrogen, 1 oxygen, and you can just figure that out. Blood pressure, boiling point in degrees. So obviously desflurane is going to be the point of difference there. You need a special vaporizer, and it is definitely on the odd side, as well as nitrous and xenon because they're gases. So if you're going to be asked about anything, it's going to be the saturated vapor pressure and boiling point of desflurane. Now MAC, again, you'll know these because these are completely things that you've used in your practice, except for maybe xenon. And again, what's interesting is that you know all the data, plus that nitrous is greater than 1 MAC. Blood gas partition coefficients, again, these are probably worthwhile knowing, as well as the MAC, but 0.42 for DES, 0.47 for nitrous, obviously very interesting numbers, and 0.14 for xenon. Oil gas, I mean, except for the Overton-Meyer equation, I haven't really found a use for memorizing those either. And then odor, irritant for isoflurane and desflurane is pungent. So again, boiling point, nitrogen and xenon are gases. That's interesting. DES needs a special vaporizer. MAC is known through experience, and the oil gas partition coefficient is inversely related to MAC, and the blood gas partition coefficient is commonly asked, therefore useful to know. So again, trying to make a really complex table a lot simpler just through a qualitative analysis of it. Okay, what are the pharmacokinetics of these opioids? So yep, take about a minute or so, and we'll go through it and see how many you can just come up with. Okay, just to go through this. Massively annoying table to learn, but if I just highlight the points, let's say for elimination half-life, remifentanil, obviously the clear winner there, with alfentanil running a close second. Clearance, they're all pretty similar except alfentanil and remifentanil. Volume of distribution is particularly low for alfentanil, and that probably is part of why it's got a rapid offset. And then plasma protein bound, pretty high except for morphine. pKa is significantly different for alfentanil and remifentanil, and the relative solubility, I mean, fentanyl is far ahead, hence the rapid distribution and the offset due to distribution with fentanyl, and which I'm just reiterating here. So half-life, alfentanil is low because of its low volume of distribution, whereas Remi has a very low half-life because of esterase power. pKa, alpha, and Remi, highly unionized, therefore equals rapid onset. And lipid solubility, fentanyl, fast offset due to redistribution, but also you can use as patch, as a patch because of that high lipid solubility, therefore rapid transference through skin. And then metabolites, morphine and pethidine have active metabolites as well. Okay, take a minute, go through some local anesthetic tables. Okay, so hopefully people got some good qualitative numbers down, find some points of difference. Okay, so onset fast for lignocaine and prilocaine. Duration of action is long for the ones that we obviously know are long, ropivacaine and bupivacaine, which we use time and time again. Then I've gone straight to percentage ionized, but there's significantly difference of lignocaine and prilocaine have a much higher percentage versus the other ones that we use commonly, ropivacaine, bupivacaine. And then plasma protein bound, 95, 94 for the long-acting ones, with a much higher lipid solubility for bupivacaine and a longer immune elimination half-life as well. And so obvious patterns again, onset is remembered with clinical experience, protein binding equals duration of action, therefore, and elimination. Therefore, we know that ropivacaine and bupivacaine are longer, so hopefully you can note those numbers down. Onset is pKa again. Yeah, let's go through the muscle relaxants. Just try to fill this table out as best as you can. Take a minute to do that. Okay, and obviously this is probably a far less catastrophic table to go through. But let's just go through this anyway. So a lot of the detail here is the fact that, pancuronium, vecuronium, rocuronium, they're metabolized, I guess, percent metabolized a lot less and eliminated in urine and bile, whereas the other drugs, all the benzoyl isoquinoliniums and mivacurium, they are very highly metabolized in the plasma. So the points of difference really are the onset, doses, and metabolism, which you already know. Metabolism is the greatest point of difference. Atra and cis-at, non-organ dependent, whereas ROC, VEC, and PANC, renal and hepatic excretion really, and protein binding is all low, and volume distribution is all low, mainly because they're polar molecules. Okay, so I thought I'd just go through that as an exercise in these really complex tables, and hopefully, you get something out of that, start by having an understanding of the qualitative differences. And when I thought about this topic, obviously I'm trying to think of other ways of teaching complex things and how to memorize lots and lots of data, because that seems to be a lot of what we do in medicine. I'm thinking there's a lot of other drills that I found really useful. I'd have sheets of graphs for all the different systems, respiratory, cardiac, neuro, renal, 3-minute series of questions for series of papers. Those are the drills that I find useful as well. Structure activity relationship drills, definition drills, compare and contrast agent drills. But you can really, instead of just doing one short answer question or a whole viva, I found that was obviously the way you want to play in the exam. But to get there, it's just like any other sport. You want to practice hitting, kicking that soccer ball into the net. You want to practice penalty throws. You want to practice sprints. You want to do all the things in a drill fashion. So once you get to the actual game, you're able to, perform really well. That's all from me, guys. Useful drills for maximum impact, structures for answering questions, categorization, learning tables and points, tables of data and points of difference. Thanks very much for having me, everyone. Thanks a lot, Kathy, for organizing, and Valentina.
No, thank you so much. I appreciate your time. You're over WA as well, so thank you.
No worries. And again, just from, I think we all know how hard this exam is. I really, really, really wish you the best of luck. Keep positive, do whatever it takes to stay positive doing this. And hopefully see you guys on the other side. And just know that this exam doesn't define you. Trust me that even if you fail this exam, you will go on to be absolutely fine in life. So yeah, all the best and good luck on the other side.
Thank you. Thanks.
Amazing. Thank you.